Yes, please. Now, welcome to the third lecture का second part. हमने beta 2 agonist के बारे में पढ़ा था. Now we will be talking about the M3 blockers as well, and we will be talking about phosphodiesterase inhibitor. ठीक है, हमने M3 ब्लॉकर्स के बारे में क्या पढ़ा था कि वो M3 रिसेप्टर जो पैरासिम्पैथेटिक सिस्टम में होते हैं उनको ब्लॉक कर देता है ताकि ब्रोंकोडाइलेशन हो. And what were the M3 blockers we studied in the last section? That was the ipratropium bromide and tiotropium bromide. याद है, ये हमने दिया था, है ना? How do we basically, how do we administer this drug? By inhalational route, है ना? एंड फिर मैंने एक क्वेश्चन भी पूछा था कि डू यू थिंक दैट एनी ब्रोंकोडाइलेटर कैन बी गिवन अदर देन इनहलेशनल रूट? Your answer should be yes. You can give by oral or IV route. That is your phosphodiesterase inhibitors. Phosphodiesterase inhibitors are bronchodilators, beta, and they are the ones that can be given by oral or IV route. लोगों को यही लगता है. See, normal cases में yes, in day-to-day life we always give inhalational route. We always give beta 2 agonist. We can give M3 blockers as well, है ना? But by oral or IV route, theoretically you can give phosphodiesterase inhibitor as well. Now, there is something that we need to understand with M3 blockers. M3 blockers can cause paradoxical bronchoconstriction. What do you mean by that? Right? मतलब एक पेशेंट था, उसको ब्रोंकोकंस्ट्रिक्शन हो रहा है. He took the M3 blockers. Now the condition got worsened. But M3 blockers are supposed to be bronchodilators, yes. But sometimes M3 blockers can cause paradoxical bronchoconstriction. Yes, please. They can cause paradoxical bronchoconstriction. That can be due to some impurities or hypertonic saline. Right? So because of the hypertonic saline in the nebulizer, or because of some impurities, the M3 blockers can worsen the condition. They can cause paradoxical bronchoconstriction as well. So in some patients, ipratropium and tiotropium instead of bronchodilation will cause bronchoconstriction. This is called as paradoxical bronchoconstriction. Why does it happen? Due to some impurities. What are the impurities? The impurities are benzalkanium and EDTA. So due to EDTA or benzalkanium, these kind of impurities can cause bronchoconstriction to happen, paradoxical, and due to hypertonic saline in the nebulizer. This I want you to just learn. This is a concept that you need to remember. That M3 blockers, we know the mechanism of action, we know the examples, but sometimes M3 blockers can cause bronchoconstriction, can worsen the condition. What is that? Paradoxical bronchoconstriction. Why is it due to? It is due to hypertonic saline in the nebulizer or due to some impurities like benzalkonium or ETA. Okay. Now we will move on to the phosphodiesterase inhibitor. Phosphodiesterase inhibitor के बारे में हमने पहले सेक्शन में ना ही कुछ एग्जाम्पल डिस्कस किए थे, ना ही मैकेनिज्म ऑफ एक्शन डिस्कस किया था, खाली रूट डिस्कस किया था, है ना? So what was the route? The route is oral route or IV route. And what about beta 2 agonist and M3 blocker? By inhalational route. Now phosphodiesterase inhibitor, what is the mechanism of action? Obviously, they will inhibit the phosphodiesterase enzyme, and that will lead to increase in cyclic AMP, and that will cause bronchodilation. So phosphodiesterase inhibitors are going to inhibit the phosphodiesterase enzyme, that will cause increase or decrease in cyclic AMP, increase in cyclic AMP, and that will lead to bronchodilation. Also, they basically block the adenosine A1 receptor. Learn. You have to learn this. That phosphodiesterase inhibitor, apart from inhibiting the phosphodiesterase enzyme and apart from increasing the cyclic AMP, they also block the adenosine A1 receptor. That will also lead to bronchodilation. And they also increase the activity of histone deacetylase, which brings about the anti-inflammatory action. right? So that is why, obviously, है ना, obviously bronchial asthma is an inflammatory reaction. So we want the anti-inflammatory reaction to produce. And how will that produce? By increasing the activity of histone deacetylase. Yes. Firstly, we understood about the M3 blockers in the previous section, that they are given by inhalational route, tiotropium bromide and ipratropium bromide. They are going to block the M3 receptor. They are going to, inhibit the parasympathetic system. That will lead to bronchodilation. Then in this section, we started that they can also cause bronchoconstriction, worsen the condition, that is called as paradoxical bronchoconstriction. That is due to impurities like EDTA or benzalkonium, or due to hypertonic saline in the nebulizer. Then we came up with phosphodiesterase inhibitor, where we spoke about the route, that is the oral and the IV route that they can be given by. And we understood the mechanism of action, that they are going to inhibit the phosphodiesterase enzyme, due to which the cyclic AMP will increase. Exactly. And that will lead to bronchodilation. They will also inhibit which receptor beta? Adenosine A1 receptor. And are they increasing the activity of something? Yes, they are increasing the activity of histone deacetylase, by which the bronchodilation, or rather by which the anti-inflammatory action is produced. So what are the examples of it? The examples of it is theophylline and aminophylline. So theophylline and aminophylline can be given in asthma. Why? Because they are bronchodilator. Which bronchodilator? Phosphodiesterase inhibitor. What do? They inhibit the phosphodiesterase enzyme, inhibit the adenosine A1 receptor, increase the activity of histone deacetylase. Okay. Given by which route? Oral IV route. Okay. Are there any side effects of these drugs, that is the aminophylline and theophylline? Yes. So when they inhibit the phosphodiesterase enzyme, there are mostly GIT side effects. Nausea, vomiting, diarrhea. Apart from that, headache. Obviously, headache is not a GIT side effect, but yeah, headache can occur. Arrhythmia can occur. So we basically go with NVD, that is nausea, vomiting, diarrhea, that is the GIT side effect, headache and arrhythmia. What are the side effects that is caused by the phosphodiesterase inhibitors when they block the adenosine A1 receptor? Again, that can lead to arrhythmias, diuresis and epileptic seizures. Okay. So what are the side effects of the beta 2 agonist? Tremors, tachycardia, hypokalemia, tolerance, hyperglycemia. Very good. What are the side effects of M3 blocker? Paradoxical bronchoconstriction. What are the side effects of phosphodiesterase inhibitor? Nausea, vomiting, diarrhea, arrhythmia, headache, when they inhibit the phosphodiesterase. But when they inhibit the adenosine A1 receptor, arrhythmia, yes, diuresis, yes, epileptic seizures. Epileptic seizures. Yeah, very good. Very simple. Up tak so far so good. Yes. So basically, if I have to talk to you about the mechanism of action, they inhibit the phosphodiesterase, increase the cyclic AMP, leading to bronchodilation. Adenosine A1 receptor को भी block करते हैं and increase the activity of histone deacetylase, which brings about an anti-inflammatory action. There are GIT side effect, nausea, vomiting, diarrhea, headache होता है, arrhythmia होता है, and in case of adenosine A1 receptor blockage में there is arrhythmia, there is diuresis, epileptic seizures. And now a special note that you need to understand before we conclude the bronchodilators completely. We'll revise the whole bronchodilators, don't worry about that. But theophylline के ऊपर एक question आता है कि which is the order of kinetics they follow? They follow zero order kinetics. Again, your general pharmac reference that they follow zero order kinetics. Yeah. Okay. Next thing which is there, mind you. Yeah. So are they prone to drug interaction? Yes. Yes. Because they are metabolized by the microsomal enzyme, they are prone to drug interaction. Smokers में हमें theophylline का ज्यादा डोज देना पड़ता है. Why? Because smoking will lead to enzyme inhibition, and if there is enzyme inhibition which is there है ना, it causes basically enzyme induction, sorry not inhibition, enzyme induction. मतलब क्या है कि थियोफाइलिन जो है, yes, theophylline gets metabolized by an enzyme, that is the microsomal enzyme. If a person smokes, it will increase the enzyme, so there will be more metabolism and lesser theophylline. Just a second. Yeah, sorry. Yeah, so I was saying that theophylline which is there, it is metabolized by the microsomal enzyme. If there is microsomal enzyme which is metabolizing the theophylline, and if a person is smoking, smoking is an enzyme inducer. It will induce the enzyme, it will cause more number of enzymes to be produced. Which enzyme? Which are metabolizing the theophylline. So जाहिर सी बात है theophylline in the body will be lesser because it's metabolizing. Why? Because smoking does increment in the microsomal enzyme which are metabolizing the theophylline. So smoking is an enzyme inducer. But on the other hand, there is erythromycin, there is ciprofloxacin. Yes, ciprofloxacin. Ciproflox is given against which kind of microorganism? Pseudomonas, right? Pseudomonas के against we give ciproflox, but that's not nowhere related, है ना? मैंने ऐसे ही पूछ लिया अगर microbiome आता है तो. So ciprofloxacin and erythromycin, they are enzyme inhibitor. So if they're enzyme inhibitor, if they are reducing the enzyme which is metabolizing the theophylline, theophylline will be more stronger. Now it's not metabolizing. Why? Because erythromycin and your ciprofloxacin, which are the enzyme inhibitors, they are already destroying the enzymes. So now your basically theophylline is much there in much more quantity in the body. So that leads to theophylline toxicity. But theophylline deficiency is caused by smoking. Why? Because they're enzyme inducer. समझा? ये general pharma का concept है. Yes. So we will revise first this section and then we will revise the whole of the thing. M3 blockers में what is the side effect? Paradoxical bronchoconstriction. Why? Because of the hypertonic saline in the nebulizer and impurities like EDTA and your, yes please, EDTA and your benzalkonium. है ना? Apart from that, basically if I have to talk to you about the phosphodiesterase inhibitor, they will inhibit the phosphodiesterase, by which what happens is that it will increase the cyclic AMP causing bronchodilation. They also block the adenosine A1 receptor. Apart from that, they also increase the activity of histone acetylase, by which what will happen? Anti-inflammatory action will produce. Is there any side effect? If we talk about the side effect of the phosphodiesterase inhibitor, when they inhibit the phosphodiesterase, nausea, vomiting, diarrhea, headache, arrhythmia. What about the basically side effects when we talk to you when the phosphodiesterase inhibitor inhibit the adenosine A1 receptor? Arrhythmia, diuresis, epileptic seizures. Yeah. Then we have the examples of phosphodiesterase inhibitor which are given by oral or IV route, which are aminophylline and theophylline. Theophylline follows which order of kinetics? Zero order of kinetics. It gets metabolized by microsomal enzyme. Smoking is an enzyme inducer or an enzyme inhibitor. Enzyme inducer, it will increase the amount of the enzyme, causing deficiency of the theophylline in the body. But erythromycin and ciprofloxacin, the one given against the pseudomonas, they will cause the reduction in the microsomal enzyme. They are enzyme inhibitor that will increase the theophylline in the body, Hannah, and that will cause toxicity of the theophylline. So please allow me to revise the whole thing. We first went with bronchodilators, wherein bronchodilators are made you explain that if an acute attack of asthma ka case occurs, you cannot treat it if you don't have bronchodilators. Bronchodilators were of three types: M3 blockers, beta 2 agonist, and phosphodiesterase inhibitor. Yes, M3 blockers used to block, or rather they used to basically inhibit the M3 receptors, inhibiting the basically parasympathetic system. Ipratropium bromide and tiotropium bromide. Beta 2 agonists were those type of drugs which were stimulating the sympathetic system. They were stimulating the beta 2 receptor. That was leading to bronchodilation, right? What were the examples of the beta 2 agonist? Yes, salbutamol, terbutaline, salmeterol, formoterol. Salbutamol and terbutaline were fast acting but short acting. Salmeterol was slow acting but long acting, and formoterol, a 3-star drug which is there, fast acting and long acting. In prophylaxis, what do we prefer? Long acting. That is why we give salmeterol and formoterol. In acute attack of asthma, what do we prefer? Fast acting. That is why we give salbutamol, terbutaline, formoterol. Right? What are the side effects of the beta 2 agonist? Tachycardia in overdose, tremors being the most common, hypokalemia, which is a T-wave change, and also tolerance develops. Hyperglycemia or hypoglycemia and beta 2 agonist? Hyperglycemia. M3 blockers, I told you the mechanism of action given by inhalational route. They basically can cause paradoxical bronchoconstriction due to impurities like EDTA and benzalkonium, and due to hypertonic saline in the nebulizer. Apart from that, basically, I also spoke to you about the phosphodiesterase inhibitor, which is given by oral or IV route. Examples being aminophylline and theophylline. 3 mechanism of action. Yes, please. First mechanism of action, inhibit the phosphodiesterase enzyme. That will cause increase in cyclic AMP, leading to bronchodilation. Do they inhibit another receptor? Yes, adenosine A1 receptor. And do they increase the activity of histone deacetylase? Yes, that will lead to anti-inflammatory action. Any particular side effects? Nausea, vomiting, diarrhea, arrhythmia, headache when they block the phosphodiesterase enzyme, and arrhythmia, diuresis, and epileptic seizures when they basically block the adenosine A1 receptor. They follow a zero order kinetics, get metabolized by enzyme. Smoking will induce, it's an enzyme inducer, increase the enzyme that is metabolizing the theophylline, leading to the deficiency. Erythromycin and ciproflox, they are the basically enzyme inhibitor. They will decrease the number of enzymes which are metabolizing the theophylline. So theophylline basically toxicity occurs in the body. With this, we have completed lecture 3. I hope that basically you understood the bronchodilators. In the next lecture, we will talk about the drugs that act on the leukotriene. I hope you understood this lecture very nicely. Sorry for the minute glitch that occurred in between, but yeah, I'll see you in the next lecture. Bye-bye.